Hello, my name is Dr. Dewan S. Raja. Today I will discuss about stellate ganglion, also called cervicothoracic ganglion. The inferior cervical sympathetic ganglion may fuse with the first thoracic sympathetic ganglion to form stellate ganglion. This happens around 80% of population. Sometimes they may not fuse. We have the sympathetic chain of ganglion. The inferior cervical sympathetic ganglion may not fuse with the first thoracic sympathetic ganglion. Sometimes inferior cervical sympathetic ganglion may fuse with thoracic 1, thoracic 2, even thoracic 3 ganglion. So size of the ganglion is also variable as well as its location. Stellate ganglion is located approximately at the level of the transverse process of the 7th cervical vertebra. It is situated about 2 finger breadth above the sternoclavicular joint when the patient is lying with extending the neck. Okay. It is located posterior to the apex of the lung. The sympathetic innervation to the head, neck, upper limb passes through the stellate ganglion. It provides gray rami communicants to the ventral rami of C7 and C8. Activation of stellate ganglion increases the rate and contractility of the heart. Okay, so here is the stellate ganglion formed by the inferior cervical sympathetic ganglion and the first thoracic sympathetic ganglion. Okay, and we have 3 cervical sympathetic ganglion: superior cervical sympathetic ganglion, middle cervical sympathetic ganglion, and inferior cervical sympathetic ganglion. In 80% population, the inferior cervical sympathetic ganglion fuse with that of the first thoracic sympathetic ganglion, form a star-shaped ganglion. We call it stellate ganglion, also called cervicothoracic ganglion. Okay, so this is the stellate ganglion, and if there is any destruction of stellate ganglion, damage to the stellate ganglion, that may lead to Horner syndrome. Horner syndrome is characterized by ptosis, there is drooping of the upper eyelid, so palpebral fissure is narrow. Meiosis, that means constriction of the pupil. Pupil is constricted. Pupil is the gap in the iris, and it is constricted by the action of the sphincter pupillae muscle. Anhidrosis, lack of sweating because of the damage to the stellate ganglion, damage or compression of the stellate ganglion. Hyperemia and flushed skin, that is also possible because sympathetic are vasoconstrictor. If that is not supplying properly, there will be vasodilation and there will be flushed face. You can also add enophthalmos. The globe of the eye is pushed backward. We call it enophthalmos or sinking of the eyeball. Okay, these are the features of damage to the stellate or cervicothoracic ganglion. Okay, so we have one therapeutic use of stellate ganglion. Stellate ganglion block is one of the important therapeutic purpose in certain complaints or some certain clinical condition. This is done through ultrasonic guidance by a well-trained licensed physician, because we have a lot of structure close to stellate ganglion, like the vertebral artery, the carotid sheath there, okay, the subclavian artery, the brachial plexus, so even the internal jugular vein. So it should be done by ultrasonic guidance by a well-trained licensed physician. What are the indications for stellate ganglion block? One is hyperhidrosis, that means excessive sweating. Okay. Phantom limb following upper limb amputation. So that may be the feeling of a person whose upper limb has been amputated. They have still pain and they feel their limb is present there. Okay, it is not been amputated. They think in that direction. That is phantom limb, and that is managed. That type of pain is managed by stellate ganglion blockage by local anesthesia. Refractory angina, complex regional pain syndrome. It may be vascular pain. It may be some type of viral infection pain, vascular insufficiency. So there will be vasodilation. Diagnosed in case of Raynaud's phenomenon, we need vascular sufficiency. Diagnosis before a sympathectomy surgery. So before sympathetic ganglion removal, we can inject the stellate ganglion, the anesthetic. We must find out whether it is effective to that patient. So he may go through surgery. Horner syndrome. What is Horner syndrome? Result from damage to the stellate ganglion, that is apical lung cancer, because stellate ganglion is on the posterior aspect of the apex of the lung. Surgical resection. Okay, if any region, if the stellate ganglion is taken out, then we'll get Horner syndrome. Okay, or any trauma or injury from the passage from hypothalamus to the spinal cord to the cervical sympathetic ganglion. Any side trauma may lead to Horner syndrome. Any of the pathway from hypothalamus to the sympathetic ganglion, anywhere there is any type of trauma damage, then we should have a Horner syndrome in that situation in our patient. Horner syndrome is characterized by ptosis, that is drooping of the upper eyelid, miosis, constriction of the pupil due to the action of the sphincter pupillae muscle, and hydrosis, lack of sweating on the affected side. Okay, in ophthalmos, the eye globe will push back, so there is called shunkening of the eye ball, and flushing of the face due to excessive blood flow, because if we can remove the sympathetic part, there will be no vasoconstriction, so there will be vasodilation and flushing of the face. Okay, so you got the indications for stellate ganglion block. And what is Horner syndrome? Horner syndrome is a condition when the stellate ganglion is compressed, blocked, or damaged. Okay, Horner syndrome has many other causes like that of neck injury, head injury, hypothalamic injury. But apical lung cancer, Pancoast tumor may lead to the condition called Horner syndrome with all the features. It is possible. And that's all about the stellate ganglion or cervicothoracic ganglion, its location, and stellate ganglion block by local anesthesia. What are the indications? So that's all for today. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful and blessed day. Bye now.